It's my pleasure today to discuss this interesting case of post-parathyroidectomy hypoparathyroidism. We have several audience and attendees from Mansoura University Division of Nephrology. We have the head of the division, Dr. Ghada Al-Qanishi, and we have the pleasure also to have Dr. Ahmed Halawa. He is a surgeon, a transplant surgeon and parathyroid surgeon at the University of Liverpool. So we are going to discuss the case. First, Mahmoud Sabh is a resident at Mansoura University Hospital, is going to present the case, then we'll open the floor for discussion. Mahmoud.
Shukran, Turam. Thank you. Our patient is 30 years old, male patient from Mansoura, single, non-smoker. He works as a mobile technician. He's a CKD patient on chronic hemodialysis. He complains after parathyroidectomy, he complains of blurring of vision and diffuse bone pain. Our patient 7 years ago had attack of malignant hypertension complicated by right eye blindness, but left eye was having good vision from it. Since then, serum creatinine started to rise. He started hemodialysis 6 years ago. On regular follow-up of his CKD MBD profile, the intact PTH was persistently high, above 2000, and calcium 9.5, phosphorus 7.5. He had mild, infrequent heel pain. All medical trials with sinacalcet and other pharmacotherapy failed to control this high PTH. So he's referred to parathyroidectomy 7 months ago. After the surgery, our patient had severe hypoparathyroidism, severe hypocalcemia, in spite of maximum doses of oral calcium and active vitamin D. IV calciums, he received 5 ampoules twice weekly after during each session, and also failed to solve the problem of severe hypocalcemia. The serial lab for CKD MBD profile was after the surgery, intact PTH was 5, 2.3, and the last 1.2. The calcium level was 4.7, and then 6, and then 6.2. All severe hypocalcemia in spite of maximum medical therapy. Phosphorus was 3.7, 3.5, and 3.6. 2 weeks ago, he started to complain of blurred vision in his remaining left eye, although he had a good vision from this eye before. First, the blurring of vision was only during calcium infusion. Then it progressed to be persistent blurring of vision. Ophthalmologist told him that he can't find any obvious cause for the blurring of vision except for calcium deposition in his eye. Our main questions here: where does all that calcium go? Too much calcium in IV infusion, and barely more than 6 or 7. Can we explain the vision loss or the blurring of vision by the calcium? And is there a role for the allogenic parathyroid transplantation? And how can we manage the immune suppression during this? If you can help us, Dr. Ram.
Very good. Thank you, Mahmoud, for this nice presentation. First, I would like to ask you some questions about this case. What was the 25 dihydroxyvitamin D level for this case?
Oh, yes. Sorry. What's the vitamin D level?
Mahmoud, can you hear us?
Yes. We didn't do the level as we don't do that routinely, but it was we are giving the maximum dose.
Okay, so just to check the vitamin D level for this patient.
Okay.
Second is, do we have any bone assessment? Did you do any DEXA scan on this patient?
No, his main complaint. No, we didn't do the bone scan.
Okay.
What's alkaline phosphatase?
Alkaline phosphatase. Alkaline phosphatase, I think.
Okay, if you don't have it, that's fine. We are going to discuss the importance of these biomarkers in the management anyway. So why does this patient have end-stage kidney disease? He's too young. What was the reason for his kidney failure?
Hypertension. He had a malignant hypertension.
Okay. Does he make any urine?
No, at all.
Zero. For how long he has been on dialysis now?
6 years.
6 years on dialysis.
Yes.
I might miss that. Did you mention his serum phosphorus level and magnesium levels?
Phosphorus was 3.5. Magnesium was normal. We did it before.
Do you mind, Mahmoud, stop slide sharing, please? Yeah.
Very good. Okay. Just last question. Do you have any idea about possibility of cardiovascular calcification for this patient?
We didn't screen for that, but his cardiac function, usual echo, it was okay.
But you don't know if he has any cardiovascular calcifications?
No.
Okay, okay, very good.
He will have.
Probably, yeah, absolutely. Yeah, agree. Oh, okay, very good. Let me share my slides. I have a similar case that was presented to me by the Mansoura Urology Nephrology Center resident and fellows several months ago. So I'm going to present this case. It's very similar, so I think it would be better to combine both of them for discussion. Then we'll open. I will give some insights about the problem of hypoparathyroidism after parathyroidectomy. Then we can discuss these two cases together. This.
Dr. Are you there?
Yes, can you hear me or not?
I mean, no, you were not talking.
Oh, okay, sorry. So let me, so do you see the slides?
Yeah,
Yes.
we see the slides.
Okay, so this case is a 20-year-old female with end-stage kidney disease of unknown etiology. And she is on dialysis since December 2012. She presented to Mansoura Urology Nephrology Center for evaluation of transplantation. But when they did the evaluation, they found that she has a limping gait. They did a CT scan, and they found that she has right femur greater trochanter cyst. Her BTH initially was more than. Somebody need to mute his mic, please. So the BTH was over 2,000, alkaline phosphatase was over 400, serum phosphorus was 5.5, calcium was normal. So they sent this patient for parathyroidectomy in February 2013. And here is the lab parameters after the parathyroidectomy very early. BTH went down to 45. The corrected serum calcium level went down to 6, and the serum phosphorus level was 6.5. So this patient, they give a lot of calcium, vitamin D, try to normalize serum calcium level. It wasn't normal, but was, you know, on the lower side with mild hypocalcemia. Then she received a right iliac allo transplant April 2013 from a mother who was 39-year-old with one haplotype mismatch with induction therapy with basiliximab, and she was steroid-free, so she was only on Prograf and Celsap. And after the surgery, she was making very good amount of urine. She was actually polyuric, 6-7 liters of urine a day. Creatinine was very normal. Blood count was good, but serum calcium went down and BTH went down further. So it was almost unmeasurable, very low BTH level. So she had persistent hypocalcemia after kidney transplantation, and she was admitted several times to the hospital because of seizures. BTH was persistently less than 10 picogram per ml, and she was on mega doses of calcium and vitamin D. 2 years later, she came in and presented with something different. Now she has severe headache, especially in the morning. She has blurry vision, and on exam, her blood pressure was normal. She doesn't have any neurological deficit, no visual field defect, and MRI and MRV both were normal. But the fundoscopy showed bilateral papilledema. So I think this is a very clear case of benign increase of intracranial tension. We call it pseudotumor cerebri or idiopathic intracranial hypertension. So lumbar puncture was done and the pressure was very high with normal image and papilledema and symptoms and signs of increased intracranial tension. That's all goes with idiopathic intracranial hypertension, which is probably because also of the severe hypocalcemia and severe hypoparathyroidism after parathyroidectomy. Here, this is the last follow-up. BTH was very low, calcium stayed very low, despite trying to replace calcium and the vitamin D. And here I'm giving more questions. So Mahmoud asked some question here. I have more question. We can open the panel for discussion. Do you consider this as successful parathyroidectomy? What is the definition and the criteria of successful parathyroidectomy? Other question, why BTH and calcium levels went down? It was low, and the patient already have severe hypopara before transplantation, but after transplantation, the patient start to come up with symptomatic hypocalcemia with seizures, and BTH went down from 40s to 1 or 2. So very low BTH, very low calcium. Why did this happen? Does kidney transplantation have any role in this process? Then other question, how to manage this patient with hypoparathyroidism and severe hypocalcemia after kidney transplantation? Is there a rule of teriparatides or anything else, or do we have just to fill her tank with calcium and vitamin D, or there is any rule for any novel treatment with teriparatide or apaloparatide or parathyroid gland transplantation? So let's try to answer these questions. Dr. Halawa, do you think this is a successful surgery? As a surgery?
Yeah, it is a successful surgery, parathyroidectomy. However, it is complicated by, as expected, by hypoparathyroidism, which counts for 20-25% of patients. there are many factors of having these complications. I will show you some of the slides, actually real cases from Mansoura. If you don't mind, I will share my slides.
Okay, I'll stop sharing.
Won't be long. Actually, there are not many slides, but just to show you what happens if the patient presents, to the surgeon late. Can you see the slides?
Yes.
Yeah. Can you see how big the gland is? This is thymus.
Mm.
Can you see how big this gland is?
Absolutely.
Can you see how big this gland is?
Yes. Looks like a heart.
So, massive. So basically, if the patient presents late, and this is what the surgeon will see inside the neck, big glands, fine. We used to say 3.5 glands to be removed and half a gland to be left. The question is how I can leave half of this gland? And what's half? Is it normal half or pathological half? We tend to, all the time, to do subtotal parathyroidectomy or total with autotransplantation. We chop a tiny bit of apparently healthy parathyroid tissue and implant it into the sternomastoid. Gland of this size is not full of parathyroid cells, full of calcifications, necrosis, fibrosis, fat. Just to be aware, the normal parathyroid, 50% of the content of the weight of the normal parathyroid is due to fat. So you have very pathological tumorous gland, and the surgeon has to leave a bit and guesswork, make sure that parathyroid cells are there, which is impossible. So the whole idea is patient presents late. In many occasions, the remaining part of the parathyroid, the surgeon left behind, not containing parathyroid cells, just calcium, fibrous tissue, hemorrhage, and necrosis. This might explain the PTH of 45 went down later on to 0. It could be due to the steroid as well, because this patient, I think in Mansoura, they gave steroid induction 3-4 days before the operation, and steroids lowers calcium. So it could be due to steroids, but I can't explain why the PTH is persistently low unless the initial figure, which is 45 nanogram per ml, was erroneous, was not right. So I'm not defending the surgeon, but I'm trying to address prevention is better than treatment, because we'll not reach this situation where you have a massive gland and it's difficult to preserve parathyroid functioning cells.
Very good. So can I share my slides, please?
Oh, sure.
Dr. Ghada, do you have any comments? Does anybody have?
Until now, I have no comment.
Okay. Can you just please stop sharing, Dr. Halawa?
Yes, you're sharing now. Stop sharing. Yes, yours.
Yeah. Okay, so very good. So first of all, we have to talk about successful surgery for parathyroidectomy. If you go with the textbook definition, successful surgery, this means that the patient doesn't have failure and doesn't have recurrence. This means that if the BTH is 2,000 or 3,000 prior to the surgery, according to the textbook definition of successful parathyroidectomy, the patient should have normalized BTH levels. These definitions were adopted from the primary hyperpara, not from secondary or tertiary hyperparathyroidism. As we know, we try to keep our patient's BTH level 2 to 9 folds of the upper limit of normal. So we try to keep it between 150 to 500 or 600 according to the reference range. So we wrote on this, we published a couple articles on this, and we try to redefine the successful surgery and try to convince people that the definition for dialysis patient and for CKD, advanced CKD patient should be different, and it should be just at least keeping the BTH between 150 to 300 instead of having 2-digit BTH level. We don't have to leave the patient with a BTH of 40 or 50 is dialysis patient. And you remember there is something called hungry bone syndrome. So the bone was hyperactive. There was very high turnover while the parathyroid gland was functioning. Then after the surgery and the BTH goes down, the bone try to get all the calcium and phosphorus. So you can see severe hypocalcemia. This is the reason that even while the patient in the OR, even before removal of the gland, we give vitamin D and calcium to avoid seizure in the OR. Other thing is we do something called turbo BTH, and I'm very sure Dr. Halawa can comment on this. We do turbo BTH intraoperative, and we get the result within 10-15 minutes. So the surgeon has the machine in the OR, and we can get very quick results. So we can just target, so the surgeon can take whatever 3 glands, 3.5, more or less, then guide by the turbo BTH level. And we did a study, I think the mean follow-up duration was more than 5 years. And we found that there is very good correlation between the turbo BTH at the time of the surgery and the long-term BTH. So if you achieve turbo BTH level in the OR, 10 minutes after removal or 20 minutes after removal of the gland with a level of 100 or 150, probably within 4 or 5 years after the surgery, you have very close numbers. But if you end up by having higher, so my advice, and we changed it here locally at University of Kentucky, we changed our practice based on our studies. So the surgeon tried to take maybe 3 glands out of 4, then do BTH. Then the BTH comes very quick and the level is 300. Then he can take more, and repeat it until he will be satisfied with the number. And we are targeting again something between 150 to 300. As Dr. Halawa said, prevention is better than cure. Absolutely, it's better than cure. Here, the surgeon, are putting us in very bad situation, and they are, giving us this patient to take care of for his whole entire life. and we need to treat him medically. There is no way that you can treat this patient medically right. There is no consensus about his management. And it's all, again, it's trial and errors. You give mega doses of calcium and vitamin D. What is the consequence of this calcium and vitamin D? Nobody knows. If you don't have BTH, where does this calcium and vitamin D goes? Mahmoud, so you put the patient, how much calcium and vitamin D daily did you give this patient?
With each session, here 6 to 5 mLs of calcium gluconate. Too much.
What about oral intake? Do you give him anything to take at home?
Maximum dose, 2 tablets with each meal.
Okay. And vitamin D, how much vitamin D do you give him?
The maximum dose also.
Okay. So where does this vitamin D and calcium go? If you give the patient, say, 2 grams 3 times a day, right? So that's 6 grams of calcium. Where does this go? Why is the patient still hypocalcemic if you are giving very good doses of vitamin D and calcium? Mahmoud?
No.
Tissues, come on. It goes into the tissues.
Right. So if you don't have, so first of all, this patient probably have adynamic bone disease or low turnover bone disease. Do you agree with that?
Of course.
Yeah. And if you give him more calcium, what will happen? You inhibit his bone more, right? So if you're giving this calcium and vitamin D, and the bone is not utilizing this calcium, and the patient, I ask you if the patient is making urine, how long he was on dialysis, and you said he doesn't, so this means that he doesn't excrete calcium in his urine, right?
Right.
So all the calcium in his body, so we have 3 compartments, either bone or cardiovascular system or intravascular, in the extracellular calcium. If there's no BTH, the BTH is the principal regulator of the extracellular calcium concentration. If the patient doesn't have BTH to start with, the patient cannot maintain normal extracellular calcium concentration. Do you agree with that?
Yes.
And the bone is not utilizing the calcium, then the calcium doesn't stay in the blood. It doesn't go to the urine because the patient is anuric. So the long-term consequences of giving calcium and vitamin D to this patient is not safe. As Dr. Ahmed Halawa said, probably this calcium goes to the soft tissue called cardiovascular calcification. This is another question I asked you. How is if you did any study on his cardiovascular system, and Dr. Halawa said probably he has a lot of calcification, and I agree with him. So again, this is not cure. We are trying to treat the number. We are trying to correct the serum calcium number, and because the patient doesn't have BTH, there is no way that we can correct his serum calcium level to normal. Okay. Do you see this slide?
Yes.
Okay, here is a calcium homeostasis. We have to understand exactly what happened with our calcium first before giving our patients, this tons of calcium and vitamin D. Calcium is the most abundant mineral in our body. About 2% of our minerals is the calcium, 2%. So if our weight is, say, 70 kilos, you will have calcium in your body more than 1 kilo, about 1.5, 1.2 to 1.6 or so kilos, So, on average, 1,200 grams to 14 or 1,500 grams. But the majority of this calcium stays in the bone, 99%, okay? Then the 1% is distributed between intracellular and extracellular. We cannot assess, when you do the serum calcium concentration, You don't have any idea about the bone, the 99%, right? You don't have any idea about the intracellular calcium because you're just, do the assay for the extracellular part, which represent 1/1000 of our calcium, okay? It's 0.1 in the extracellular space, 1% intracellular, and 99% in the bone. And even this 0.1%, which is 1/1000, when it comes to the calcemic control, only the biologically active part of this is the ionized calcium, which represent about 40% of this 1/1000. So this, whatever, I'm not good at math, but this very small fraction control everything, control our BTH, because the calcium level is the principal regulator, and hypocalcemia is the principal stimulator of the BTH secretion. So it's very important to understand the relationship between BTH and calcium, because any small changes in serum calcium concentration mean that we are only playing in less than 1/1000. And if you see a marked change in this, you are ignoring, the rest, which is 999, of this 1%. So be careful, because these changes in the calcium, when the calcium goes down from 9 to 6 or 7, this means that the total balance of the calcium here, we might have huge problem. So if you eat, normal person eat about a gram, say a gram, 1000 milligram of calcium a day, we absorb only about 20-25% of this in our gut. The rest is excreted directly in the stool. So we excrete about 750 milligram a day of calcium. Then the rest is absorbed from the gut, goes to the blood. Then, so we absorb about 200, 250. Then we excrete majority of this in our urine. If you are not in a negative or positive calcium state, you excrete majority. So excrete about 150 milligram a day. If you are excreting 200 milligram a day or so, that's too much. But average is 120 to 150 milligram. It depends on the age, the gender, and other factors as well. Then the rest, is distributed, mainly 99 goes to the bone, and very small fraction stains the blood. Mainly the 10% just stay in the extracellular fluid, and 90% control the whole environment, the whole cellular activity, include neuromuscular activity, cardiomyocytes. So this is the reason that with lowering down the calcium, you will see the patient have seizures, irritability, coma, and all kind of depression, and all kind of neuropsychiatric manifestations. And also, you will see that the patient might have prolonged QT intervals, might have arrhythmia, and his heart can stop in severe cases. Okay, so what happened here? We mentioned that the majority of the calcium we absorb from the gut is excreted in the kidney. Small fraction is reabsorbed from the kidney, and this fraction goes either to the blood or intracellular or extracellular space. What happens if you don't excrete, like our patient? He doesn't excrete calcium in his urine because he is anuric, right? Then his bone is dead because he has probably severe low turnover bone disease. So any calcium you're giving to this patient, if you're giving 4 or 5 or 6 grams a day, doesn't go either to the bone or to the urine. Then you check the extracellular calcium concentration and stay low. This means that this patient probably is calcifying his cardiovascular system. Very important. This study, when you do a balanced study, you need to see the in and out, the intake and output, right? So a major thing in the calcium balance study is you need to do a 24-hour stool and urine calcium content. So you have to collect not only the urine for 24 hours, but also the stool, which is a little bit, offensive. So anyway, they did this for just 6 patients, CKD patients, and another 6 normal volunteers. And they put them either on low calcium or high calcium for these 2 groups. When they put the normal people with normal kidney function on a negative calcium balance, on a low calcium intake, they end up by having low calcium balance. They start to lose some calcium, right? And if you put them on high, so the low is 800 milligram a day, the high is 2 grams a day, you see that they will be on positive calcium balance about 400 milligram every day. If you do the same for the CKD population, and again, this is CKD stage 3 and 4, so these patients still have some kidney function, they are not dialysis patients. You see that these patients, when they are on a high calcium intake, they end up by having severe positive calcium balance, right? You see that here. And if you put them on a low calcium intake, the negative calcium balance is not too bad. But their problem is that when they are on a higher calcium intake, they start to have marked increase of their calcium balance. So they are retaining calcium. And if you see here on the right side of the slide, that serum calcium doesn't move. Serum calcium stay around the same. It doesn't mean that they are on a positive calcium balance. It doesn't mean that their serum calcium concentration goes up. There's complete disconnection between the serum calcium concentration and the total calcium balance, because as we discussed, it's only less than 1 per 1,000 of the calcium is in the extracellular space. So there is no replacement therapy for hypoparathyroidism. There is no hormonal replacement therapy for hypoparathyroidism. And there are several studies, randomized controlled trial, they try to use calcilytics. We are familiar with calcimimetics, right? Calcimimetics suppress the BTH. Calcilytics actually do the opposite, stimulate the BTH secretion. But these 3 randomized controlled trials, they failed because of lack of efficacy. So we are left with nothing. Vitamin D, calcium, we talked about this concern. So how can we improve their calcium level? Sun exposure is very important. Why sun exposure is, if you are getting more vitamin D through the sun, it's better from getting it through the supplements. Do you know, Mahmoud, why is it better to get vitamin D from the skin rather than to give the patient a lot of vitamin D?
No.
Okay. So the skin is very smart, actually. So the skin changes the sun, it changes the 7-dehydrocholesterol in the skin to 25 cholecalciferol. And this process is very smart. So the receptor on the skin, it turns off once it reaches the level that it can see the patient is on a positive calcium level, or, it shut down the receptor once it sees that the patient is satisfied and doesn't need any vitamin D. But this doesn't happen in the gut when we eat, especially with supplements. Yes, there is down regulation of the receptor, but it doesn't shut down completely. So we can still get, vitamin D toxicity, hypervitaminosis D, and this is the reason that I told you how was the vitamin D level, because if you are giving too much of vitamin D, the patient might be vitamin D intoxicated, right? So you have to be careful giving very big doses. Again, vitamin D, very big dose of vitamin D can suppress the bone formation, can induce also low turnover bone disease. So we have to be careful. But when it comes to sun exposure, especially in Egypt, there is a lot of sun. So you see, if you are living in sunny state like California, you know, in San Diego, you need just 7 minutes. If you have good exposure of your body to the sun, you can get all your vitamin D requirement from the sun. Then if you are living in a colder state, if you have less sun exposure, you need, you know, prolonged period of sun exposure. Again, this studies was done in white people, so it's not on darker skin and also not in obese. This study actually was done for patients with chronic kidney disease. Two groups of patients, they give one group of patient ultraviolet and the other group, they give supplements. And as you can see here, I mean, patients who you know, have ultraviolet exposure, their vitamin D level was better. Their actually gene expression, they did a gene expression study, and also the vitamin D receptors was much healthier. So sun exposure is very important. It's better to get vitamin D rather than just to give, you know, very big doses of vitamin D. Also, don't forget, you can get calcium and vitamin D from food. It's not everything is medicine. We as physicians, we don't just treat with medicine or surgery, right? We have to talk about non-pharmacological intervention because this is natural, this is physiological. It has, the safety profile is much better. When it comes to pharmacological intervention or surgical intervention, it's not free of side effects, right? So talk to the patient about eating healthier. I mean, the calcium, you know, sesame, for example, you know, nuts and almond and a lot of, as you see here, you know, tooth, you know, or whatever, several, you know, resources that you can give the patient instead of giving medicine. You can improve their calcium intake and their vitamin D intake. Vitamin D, you can just with 3 ounces of salmon, you can get more than 500 units of vitamin D. So if you're giving the patient, you know, 1,000 unit or 2,000 units of vitamin D, instead of giving supplements, you can do this with the diet. Just 3 ounces of salmon, maybe 1 cup of milk has 120 units, maybe orange juice, you know, fresh orange juice will give you the same thing. So don't, you know, give a lot of supplements. Try to control it non-pharmacological. Teriparatide, again, teriparatide is 134 BTH, and it's you know, recombinant hormone, but it's not a replacement. Why do we give teriparatide for this patient? To improve their bone. Actually, it's tricky because if you improve or if you correct the low turnover bone disease, the bone will utilize more calcium. So the requirement or the influx of calcium to the bone will be higher. So in general, teriparatide can improve calcium, but also can cause hypocalcemia. If the bone formation rate is going up, if the need for the calcium is going up, so the calcium will be mobilizing from the extracellular to you know, the bone compartment. So you have to be careful. Several studies show that you can improve the low turnover bone disease, the bone health, using either, I'm not going to go over this, either once daily injection or once weekly injection of teriparatide. It's mainly given to improve the BMD, the fracture risk, and the bone health. Then, I'll talk about also abaloparatide. Abaloparatide is a BTHRB, and also it has been shown that in several studies, actually it might improve the bone health better than teriparatide in CKD patients and even in dialysis patients. So Mahmoud nicely, yesterday he sent me this, and I want to hear Dr. Halawa insight about this. So yes, I saw that in the past. There is several small case series that they did the allogenic parathyroid transplantation. Mainly, these small studies were done for patients with congenital absence of the parathyroid gland in children, but also there is some has been done in dialysis patients. Of course, there is allo and there is auto transplant. Auto transplant would be much easier. The problem with allo transplant, you will need to give immunosuppressive medications. It would be the best if the patient is getting a kidney transplant, so he can get a kidney transplant and at the same time, he can get a parathyroid tissue, either from the same donor or from other donor. And I want to hear Dr. Halawa's insights about that.
Yes, actually, it's not case serious. It's just case reports of few cases done here and there. And, we have to remember, my colleagues, that, if you have case reports, there is, strong subjection to publication bias. So basically, researchers tend to publish successful outcomes rather than the negative outcomes. So if they present a case which is successful, this could mean that many cases have failed, but no one will hear anything about them. And in, I read about it, and few being done in transplant patients, as mentioned. The kidney was removed, kidney was taken from a mother and the parathyroid into the recipient. And actually, the problem with these cases, they don't last for long. Maximum 2 to 3 years, and then it fails. I wouldn't say, it's successful because, we don't have a proper study or a long-term outcome, long-term follow-up. And I would like to stress on something actually that Dr. Amr said. Actually, in CKD patients, adynamic bone disease being reported at PTH of 400. So the reference range does not apply to CKD by all means. If 45 is not normal, of course 45 in this case is not normal, because the normal, as mentioned by Professor Amr, is for 400, 500, 600. We accept up to this as well. And if you see a reference range quite ambiguous like this, 4 to 9 times the normal, means we don't know what's the normal. Another thing I would like to stress, this case there is obvious failure of medical treatment. We should prevent this in the first place. You shouldn't have a patient with CKD with PTH more than 2,000. PTH should be done regularly. Vitamin D should be done regularly and should be replaced. Here in UK, in spite of them, strong surveillance, still we see this, these patients, but some of them will fail medical treatment and because they received it, but failure of medical treatment which was not received is a failure of the treatment. The GP will pick up all these patients with CKD3 and they start giving them vitamin D and check calcium level and check PTH regularly. Because CKD3 will be seen once by the nephrologist and then followed up by the GP and referred back on an annual basis to make sure that, he's not progressing. I haven't seen this case and I don't know the surgeon who did it, but if you left the surgeon with massive, big parathyroid glands, of course, will end up by hypoparathyroidism. So we should prevent the massive increase in the parathyroid by not doing the proper follow-up, proper management while we are not yet on dialysis.
Excellent. So Mahmoud, why do you think that in this patient who received the kidney transplant, in my patient, why did PTH went down after transplantation and serum calcium went down further?
I don't know. I have no explanation.
Okay. You said it, you used to give this patient on dialysis a lot of IV calcium, right?
Yes.
Other thing is, do you adjust serum, the dialysate calcium concentration, or it's fixed?
It's fixed.
So here we can adjust for the calcium, the magnesium, the potassium. So in this case, most of the nephrologists here in USA will put this patient on high calcium bath. Again, there's safety concerns here, but this patient was getting tons of calcium, was getting dialysis. I mean, if this happened here at US, at least this patient will be on high dialysate calcium. So after transplantation, this will be all gone. More importantly, we mentioned that the output of the calcium is mainly, happens mainly in the urine. So this patient, on dialysis, she wasn't using, losing any calcium in the urine. She was anuric. After transplantation, she's making 5-6 liters of urine a day, right? Initially, and start to concentrate. So now she starts to lose calcium in her urine. Actually,
this should stimulate the rise of PTH, not the drop.
Exactly, that's a smart question. But let us agree first on the calcium part.
Yes.
So we all agree that this patient is not getting, high calcium dialysate, now is making urine. Do you know that there is a concern that this patient may have because of the hypercalciuria, right? Losing a lot of calcium because this patient doesn't have PTH. So he is excreting a lot of calcium in his urine. And when you have hypercalciuria, what problem you should be at risk of?
Polyuria, titular necrosis.
Okay, and nephrocalcinosis, kidney stones, the most, okay, Mamdouh, thank you. So the highest risk for kidney stone formation, the calcium oxalate kidney stones, is hypercalciuria, right? Yes. So this patient might actually have acute calcium deposition and interstitial nephritis from increased calcium excretion, especially in this newly implanted kidney. So we have to be careful. On the long term, this patient might have, if we don't stop this from happening, this patient might end up by having nephrocalcinosis and kidney stones, of course. And if you lose more calcium in the urine, this patient also will have more osteoporosis and bone disease. Anyway, so Mahmoud asked very good question. So if the calcium is going down, it should stimulate the BTH, right? Formation. But if the patient doesn't have parathyroid gland, how can this stimulate? This happens if the patient has some tissue, right? But probably this patient, nothing left. Very few. Other thing, patient with secondary hyperpara, even if they have very small, parathyroid gland left over, it will be stimulated by the loss of because of no kidney function. So the process itself will stimulate. The vitamin D level will be low, and the BTH, because it's very low, then the vitamin D level try to activate whatever left over in the parathyroid gland. But because of this, patients now lost the compensation. So we call it the compensatory hyperpara. He lost this compensation after transplantation. So probably he lost, this trigger. So his BTH levels went down. So calcium definitely goes down after transplantation. That's very well known. BTH depends. Some patient depends on how much left in the gland, how much this was secondary or tertiary hyperpara, because tertiary hyperpara, whatever, it doesn't have anything to do with the kidney function. It's autonomous, not dual anyway. But in secondary, it would be correlated with the kidney function. So after having better kidney function, maybe the BTH goes down, but this doesn't usually happen in patient with tertiary. So it depends on what kind of glands left over. So yeah, so what option we left for this? So as we discussed, you can focus mainly on sun exposure, on food rather than supplements and giving mega doses. You can try Parathyroid. However, you need to watch the serum calcium concentration more, closely, because actually hypocalcemia can happen. It depends on what will happen in the bone. So if the bone improves very fast, it might take more calcium. But it's a BTH, so it will help with the calcium in general. But if the patient has very dead bone, and now the bone is waking up and taking the calcium, so there is a concern here that he might consume more calcium in the bone. So you can do this. Teriparatide, again, is not a replacement. It's not hormonal replacement. You can give it for 6 months or maybe a year and see what will happen. Then, is he a candidate for a kidney transplant?
He is a candidate, but can't find the donor.
Okay.
So it's not a candidate.
So he doesn't have related donor.
Yes.
Okay. I don't know the regulation and the policies in Egypt, but if you can get him exemption, a waiver from live donor to unrelated donor, it might be an option, because he's a very young guy. I don't know how can you do that, but probably you are more familiar with the system better than me. But I think the best option for this patient is to get a kidney transplant and to arrange, and I want to hear Dr. Halawa again on that, and to arrange to get him also autologous parathyroid transplantation. Maybe when Dr. Halawa will be in Egypt in the future, he can arrange to do that while this patient is getting the transplantation, or after or before. The problem with, if you are getting parathyroid transplantation, the autologous one, without a kidney, this patient will be subjected to immunosuppressive medications. Most of the studies, or the smallest studies that I have seen, they put the patient on steroids. They treat him actually as kidney transplant patients in the first 6 months or so. So they give combination of steroids, small dose of steroids, then a calcineurin inhibitor, and after 6 months, they try to withdraw the calcineurin inhibitors and keep him on maybe a small dose, 5 milligrams of steroids or so. Again, the long-term survival and viability of the parathyroid gland here, as Dr. Halawa said, we are biased because we are hearing from the successful people, but I'm very sure, and Dr. Halawa also can tell us his experience with the implanting the parathyroid tissue, it might not survive. What do you think, Dr. Halawa?
Yes, yeah. I mean, it's quite tricky as well, because we had 2 cases in Mansoura after parathyroidectomy. There was severe hypoparathyroidism, significant and symptomatic. Lucky enough, we preserved the part of the parathyroid glands in liquid nitrogen, but we used it a year down the line. None of them did work. It looks like a preservation. We know the viability of the cells. We know will go downhill. After a long time of preservation, and this is what happened. So basically, the parathyroid, as you see, parathyroid transplantation is still in its infancy, and a few case reports. But in Egypt, we have to go through a lot of things in terms of applying to the higher officials to proceed with this kind of operation. And there is complete misunderstanding how bad the disease is. Hypoparathyroidism is, I can conclude hypoparathyroidism is a disease with no treatment. It's better to avoid it in the first place by prevention and by good surgery. And good luck.
Completely agree with that. Definitely.
And good luck.
Right, right. So, Mahmoud, highly encourage this patient to get a transplant. Other thing is, if you get a transplant, I saw several small study, as we mentioned, that he can get, a parathyroid gland from a patient with secondary or tertiary hyperpara, while the surgeon is doing it for others. He can get a consent. I don't know about the regulation of parathyroid transplantation in Egypt. Probably you need to go through a lot of, problems and try to get, because this is not, I don't think this has been done in Egypt. So you need to get approval from the Ministry of Health or whatever. Then you need to find the donor. So the donor will be another major, issue. But you can convince him that this tissue is already going to be wasted. So if we can just use part of the tissue that will be removed to help, his friend, another, dialysis patient. So I think you can get this okay, but you need to get approval for that. If you want to do this without a kidney transplantation, I think based on whatever I have read, yeah, it's okay. You have to, it's cost benefit. So you have to tell the patient that he will be on immunosuppressive medication. This immunosuppressive medication can kill him. I mean, being on dialysis with no functioning kidney, and on top of that is getting immunosuppressive medication is not an easy thing. But if the hypocalcemia is killing this patient anyway, I think it's worth to try. So you can and put him on a small dose of steroids and calcineurin inhibitor for at least 6 months. You can try that. And of course, Dr. Halawa is here, and I'm very sure that he will be very glad to help you guys with that.
I would like just to mention something. Teriparathyroid has been reported to be associated with osteosarcoma, but in animals.
Right.
So this is one of the concerns of teriparathyroid.
Right.
In addition to very expensive, very, very expensive. So, this patient needs financial support from the government if we plan to give him teriparathyroid.
Exactly. So yeah, the osteosarcoma, usually it's animal report.
Yeah, rats.
Usually happen with long-term use. So this is the reason that we limit the use of teriparathyroid to 2 years. Here in America, the FDA approval is only for 2 years. In Europe, I think they have approval to give it for up to 3 years. But again, it's all animal data. But yeah, even here, I wouldn't treat him for 2 years. I will just treat him for 6 months and see how it goes. Again, it's so teriparathyroid here, we are not going to improve. If we are improving anything, it will be mainly his bone. And again, it's not replacing, it's just improve the bone formation rate. So it's osteoanabolic. So you improve bone formation. And if the bone formation improve very fast, you might even have problem with controlling his calcium again. So yeah, it's not a solution. It's just you can try it and see if it will help. It might prevent him from having fracture in the future as well. But again, it's dilemma. And I think the surgeon brought us in this. Do you agree, Dr. Halawa?
Yes. So, the surgeon was stuck between the devil and deep water.
Right.
And left up with a very advanced disease, and he has to do something. So so it's like cancer. Neglected cases of hypoparathyroidism is like cancer. There is no cure. It's just palliation.
Right. We just need to do. It's a micro-invasive technique, and we just need to do a smart parathyroidectomy instead of being very aggressive. We need to talk. If you guys, and I would probably say that, if you talk to the surgeon before doing the surgery and explain to him that we are targeting a PTH level of 150 or 200 or whatever, 300, and try to convince him that you don't want to just change the spectrum of his bone disease from high turnover to low turnover bone disease. Just have a dialogue, have a conversation with your surgeon. Just don't send the patient to whatever surgeon that he is claiming that he's the best neck surgeon or endocrine surgeon, whatever, or head and neck surgeon. Don't do that. You have to have a conversation, and this should probably send to an expert in the CKD MBD area, somebody like Dr. Halawa or some of your surgeon guys, that you build up knowledge, and you based on the dialogue, and you teach them, they teach you, so you will meet in the midstream by the end of the day. So don't let him live in isolated island and treat him as surgically blinded technique he doesn't know the kidney blind. If he is endocrine surgeon or head and neck surgeon, probably he doesn't. Dr. Halawa knows that because he's a transplant nephrologist, transplant surgeon. So he deals with nephrology cases all the time and dialysis patient all the time. But if you send him to a general surgeon or head and neck surgeon or endocrine surgeon, he doesn't know these details. So you have to teach him, you have to talk to him. Otherwise, he will make your life miserable as this patient.
Absolutely. I mean, it's better, to make it easy for the surgeon, tell him a dynamic bone disease is a disease of high mortality and five-fold increase in fracture risk. So we are not making any favor to the patient by being a hero and removing 4 glands and left him with nothing. At least you attempt to preserve something, and if you failed, if the operation didn't go well as planned with PTH, at least you tried, but, surgeons should be aware of this. A dynamic bone disease is associated with mortality and increased fracture risk. To me, correct me if I'm wrong, Professor Ram, if he was left with hyperparathyroidism would be better than a dynamic bone disease.
Absolutely, I agree. I mean, we just want to try to avoid the extremes.
Yes, be in the middle. Yeah.
Right, modesty. So instead of severe hyperpara, he changed it to severe hypopara. We don't like that. We don't like the other way around. So just need to, even if he left us with, mild hyperpara with VTH5, 600, 700, that's okay. As nephrologists, we know how to treat that. We can give him calcium mimetic or vitamin D analogs, or, we have a lot of options to control his, mild or moderate hyperpara. But some surgeons, they are concerned about the failure. Tell them that this is not failure. To leave the patient with a VTH of 400 is absolutely fine with us.
I think, sorry, doctor, I think Dr. Ahmed Lutfi with us.
Yes. Yeah, I've seen him from the beginning, yes.
Yes.
So tell him that 400 is better than 4. Tell him that 300 is better than 30. Because we know how to treat PTH of 300 or 400, but we don't know how to treat PTH of 30 or 40. So does anybody else have any question or concerns or wants to, discuss anything related to this topic of hypoparathyroidism after parathyroidectomy? Okay, very good. I really appreciate everybody's contribution today. Dr. Ghada, go ahead, sorry.
Yeah, I want to hear from Dr. Ahmed Lutfi if you have any comment.
No, thank you for giving me this opportunity to attend this fruitful talks. I have no comments to add. Actually, my dear Professor Dr. Ahmed Halawa is covering very well the topics as related to the surgery. And maybe we are going to discuss the evolution, how to leave this enormous large gland that is pathological with calcification, fibrosis, how to leave part of it or not, because sometimes if we shop a part of it, we found that is not totally healthy or totally unhealthy glands. That's not, we think that it is unsafe to leave it. But today we consider is to leave the patient with hyperparathyroidism is better than leaving him with low BTH and dynamic bone disease. we are going to discuss more and more how to leave this small part of this glands. I don't know if there is some researches on that or not, and we're going to try, inshallah.
Very good, very good.
Inshallah.
I have several studies actually we published in the last 3-4 years, at least 3 articles on that. I can send it over, so we can also discuss it in the future if you want to have you know, another meeting with the surgeon or something. I'm very sure also Dr. Halawa will be happy to help with that, so we can discuss the problem with you know, severe hypoparathyroidectomy and how can we prevent that in the future from the medical and surgical sides.
I appreciate it.
Yes, sir. Okay. Thank you, everybody. And yeah, it was, I think, a very thoughtful discussion. And hopefully, knowledge is not, you know, if it doesn't help with our practice and how we are treating our patients, it's like double-edged sword. So we have to be careful. Now we understand more, we understand better. So I think we can treat our patients better, and hopefully these patients and other patients can benefit from this discussion. Thank you so much, and you know, I wish good luck for everybody.
شكرا.
Thank you.